Yes, we are live. Good evening, good morning, good afternoon, wherever you are watching me from. Welcome. How have you been? Welcome to my channel where we talk about health, we address medical misconceptions, and we address your medical questions. So if you're watching this video right now and you are live with me, I want you to do me a favor. Help me like this video, share this video right now, and invite your friends to come join us. My name is Dr. Frederick Unibohai. As you can see on the screen, people call me Dr. Fredo Star. And I always tell you, good life, na sense. Um, some people asked me questions and they were like, please, doctor, can you help us invite a guest to come talk about miscarriage? So we had to reach to one of our teachers. I can see somebody online, and we begged her, please, ma, help us join this program today to talk about miscarriage. She said, okay, she's going to make out time from her very, very busy schedule. Very busy. So she's joining us today to talk about miscarriage. But before we go ahead, please tell me in the comment section, where are you watching me from? We already have some people in the house. Tell me, where are you joining me from? I wish to state that we appreciate every guest that comes on this program. We appreciate them, their time. We don't take it for granted. Whenever they come on this program, we owe it so much honor. And our guest today was on this program, I think sometime last year. She was on the program and she spoke about the danger signs in pregnancy. She broke so many things about the first trimester, second trimester, third trimester, danger signs. And we are privileged to have her join us here again on the program. Our guest is a consultant obstetrician and gynecologist. She is a fetal maternal specialist. She was recently awarded the Edo Medical Personnel of the Year. Imagine, out of all the whole Edo doctors, she was awarded. It shows you that she's really, really good. She's a medical chief. She's a traditional chief. We call her triple chief, very high chief. Ladies and gentlemen, it's indeed my great honor to bring on this program one of our teachers. She's a mother, a very passionate, dedicated, disciplined, excellent medical doctor. Please, ladies and gentlemen, help me welcome on this program Chief Dr. Hilda Iyen Omoregbee. Good evening, ma.
Good evening, Dr. Fred. Nice to be on the program. All these accolades for me. I'm
Chief,
indeed humbled. Thank you very much for having
Chief,
me.
you are worth much more. I wish people just know who we have here again tonight. If you can hear me, drop a comment, drop your comment down. Let's not waste time. I know you're very busy, ma. We don't want to delay you. We know the time difference, time zone difference we have. People have been talking about miscarriage. We hear ladies complain, oh, I had miscarriage. Some say it's village people. Some will say it's because you didn't greet one woman in the village. That is why you had miscarriage. Please, can you help us, ma? Break it down. What exactly is a miscarriage?
All right. Thank you very much. I would like to discuss this topic using the following outline: an introduction, definition, incidents, the risk factors, and the investigations to be done, and of course, the treatment. The loss of a pregnancy at any stage is usually very, very devastating for the couple. So such couples need to be treated in an empathic and compassionate manner because it's a very serious issue to lose a pregnancy irrespective of the gestational age. Now, we term it miscarriage when there is loss of the fetus before the age of viability. The age of viability varies according to geographical location. So on the average, we take between 24 weeks and 28 weeks. So if a woman loses any pregnancy between from time of conception to between 24 weeks to 28 weeks, it is termed a miscarriage. Summarily put, miscarriage can occur in the first trimester, which is the first 3 months of the pregnancy, or in the second trimester, which is from the third month to about the 6 months, so that our women will understand it very well. Now, miscarriage occurs in about 1% of all pregnancies. For every couple who get pregnant, couple means the man and the female together, 1% will result in a miscarriage. Miscarriages do not just occur. Certain things make it happen. And these are what we call risk factors. The risk factors are classified under various headings. Now I will further break them down. You have epidemiological risk factors. The epidemiological risk factors refers to the age of this woman, her body build, if she's obese or if she's extremely slim, the age of her partner. Now, there's something very important about age and pregnancy. You will agree with me that the younger a woman is, the more fertile she is. And the younger she is, the better quality of egg she produces. That is why we always advise women to start having their babies at a very young age, not extreme of age, but at least an appreciable age, because during this time, you usually get the best. As a woman age, her eggs also age. And so you now start having very poor quality of egg. This poor quality egg often results in miscarriage. For instance, if the woman is about 20 years, the risk of having a miscarriage is less than 1%. But if she's 35 years to 39 years, she has a 25% risk of having a miscarriage. And if she's above 45 years of age, she has a 93% risk of having a miscarriage. So the higher the woman increases in age, the higher the risk for miscarriage. Again, if a man is above 40, there is a higher chance of his wife having a miscarriage. Because when we talk about miscarriage, there's what we call genetic predisposition. So the genes come from the male and from the female. If the male is given an abnormal gene, it results in an abnormal baby, and that abnormal baby will often result in a miscarriage. So higher paternal age, higher maternal age are both risk factors for miscarriages. Then again, any woman who smokes, primary smoker or secondary smoker, nicotine is toxic. It's embryotoxic and can affect the fetus and result in abnormality in the fetus, which will result in miscarriage. The same thing with alcohol and caffeine. That is why before a woman becomes pregnant, if she's used to these habits, we usually advise them to stop it or try as much as possible to reduce it to the barest minimum, especially during the first part of this pregnancy, because it is at that time that the baby is forming. This is what we call embryogenesis. So if you reduce toxins during this period, you have less problem and there'll be no miscarriage. Again, the weight of the woman. Women who are obese tend to be very, very big. They often have other problems that will also result in miscarriage. So this is for the epidemiological risk factors. Then we have a very important cause of miscarriage, which we call thrombophilia, antiphospholipid syndrome. Now, the sad part about this is, in many underdeveloped countries, screening for this thrombophilia is often very, very difficult because they do not have the necessary laboratory apparatus to carry this test. So you will find women having recurrent miscarriages without the doctors actually telling them what the exact cause is. Now, certain things in the woman will point to a thrombophilia. These include: one, she gets pregnant. You have clinical factors and laboratory factors. When she gets pregnant, as at the time that the pregnancy is about 10 10 weeks, let's say approaching the third month, she has done ultrasound already, and the ultrasound will say the baby is okay. Suddenly, she does another scan and they tell her the baby is already dead. So the baby dies between 10 weeks of the pregnancy inside her womb. Or she has a history of thromboembolism, meaning accumulation of blood resulting in clots in either the limb or the hand. She'll start having pain, swelling. She'll go to the hospital. There's a history of thrombosis in the peripheral vessel. Or she gets pregnant, but has 3 consecutive losses at about 10 weeks. She just keeps having this type of miscarriages. Or finally, she's able to carry this baby beyond 6 months, 7 months, and suddenly her blood pressure increases very, very high, and she has to deliver that baby before 34 weeks because of placental insufficiency. When these factors are present in a woman, they are pointers towards what we call antiphospholipid syndrome. I will talk about the investigation for antiphospholipid syndrome during our general investigation. So I just want you to note that antiphospholipid syndrome is a very important cause of miscarriage, and particularly recurrent miscarriages, which most of our doctors are not aware of and cannot diagnose in developing countries. Now, we also have a very important risk factor, which is the genetic risk factor. Like I said earlier, genetics come from both the male and the female. And these genetic risk factors, we call it parental chromosomal abnormality. When there are translocation or balance translocation resulting in structural abnormality in the fetus. So the genetics can either be from both parents or from the fetus itself. So, like we always counsel our women whenever they have a miscarriage, we tell them that some miscarriages are blessings in disguise, meaning this pregnancy was an abnormal pregnancy, ab initio. So it is nature's way of helping the body get rid of something that will be so unpleasant in the future. So this usually results from genetic abnormality, either from translocation or structural abnormalities. Then we now have anatomical abnormalities. This has to do with the woman. Remember, it is the uterus, which we call the womb, that carries the baby. So if there is any problem with the womb or the cervix, it will result in recurrent pregnancy losses. There are some women that have fibroid within the uterus. Now, fibroid can be in different locations inside the uterus. It doesn't really matter. But the one that is responsible for causing recurrent miscarriage is when it is a submucous fibroid, meaning this fibroid is at the middle of the uterus where the baby will stay. So you find the baby staying and the fibroid staying, both of them are competing for space. And the fibroid is also growing as the baby is growing. So the fibroid tends to push the baby out and results in a miscarriage. Again, some women can have a uterus, a bifurcation within in the middle of the uterus. We call it a septate uterus or an arcuate uterus. There are structural abnormalities within the uterus that you may not even know that you have unless you now start having problem. So when this type of thing occurs, it can result in recurrent miscarriage. Then there's also what we call cervical incompetence. It is the failure of this uterus to carry any pregnancy to term because there is a structural defect in the uterus or in the cervix. Why would there be a structural defect? It can result from congenital, meaning the woman is born with it, or acquired, a problem that occurred during the lifetime of this woman. Now, some women have connective tissue disorder. They don't know about it. So the cervix is very weak. Any little load you put inside, it opens up and the baby comes out. For women who have cervical incompetence, the classical way of miscarriage for them is the miscarriages occur in the second trimester, and usually they will not have any complaint. They will suddenly feel as if there is a bag in between the vagina. They feel a bulge, and before you know it, they see water and the baby is out without pain. They call it painless expulsion, and it continues as the pregnancy progresses. So you will know that the problem now is with the cervix. Now, what can make this cervix to be weak? One, if you have repeated D and C, forceful D and C, for women who go to terminate pregnancy in unhygienic situations. So the person who is doing it is in a hurry. So he will force the cervix open. And the process of forcing the cervix open, you damage the connective tissue in the cervix. When she's now pregnant, she cannot hold a pregnancy again. Or when this woman is pregnant, she has a very fast labor. Before she came to the hospital, before you know it, she's already pushing and the baby comes out very fast. The process of the baby coming out very fast can result in a tear in the cervix. Of course, once there's a tear in the cervix, you have damaged the collagen fibers in that cervix. And by the time you start repairing, it will result in incompetence. Again, there are some women that do some procedures in the cervix, like you have cervical cancer, you want to diagnose cervical cancer, you do cone biopsy, you do some treatment within the cervix. All this can result in cervical incompetence. Again, when you have a very big baby and you force yourself to deliver vaginally, it can result in that cervix being incompetent because you will overstretch the cervix. So these are the causes of cervical insufficiency or incompetence that will result in recurrent miscarriages. And these miscarriages usually occur in the second trimester, and it is characterized by painless expulsion of the fetus with associated rupture of membrane. Now, we will now go to the very common cause of recurrent miscarriage, which we can easily diagnose wherever we are, but we often do not pay attention to it. That's what we call the endocrine causes. I had this patient sometime in Nigeria, and she came. She's been having recurrent miscarriage. So as soon as she entered the consulting room, something struck me about this patient. She was obese on the big side. And so the very first question I asked her, I said, are you diabetic? Have you ever screened yourself for diabetes? She said, no. I said, is there anybody with diabetes in your family? She said, yes, her mom is diabetic. Her dad is diabetic. And I said, okay, please, I would want you to do screening for diabetes. She said, no, I'm too young. How can I be screening myself for diabetes? I can't have diabetes. I don't have any complaint. I don't have it. I just told her, I said, well, if you do the test, will there be any problem? She said, no. I said, Kalas, go do the test. And so she went for the test. When the result came out, she was overtly diabetic. And that was how her solution came. Immediately, I sent her to the endocrinologist for blood sugar control. After they controlled her sugar, she got pregnant, and this time around, we placed her on special care, and she was able to carry that pregnancy, and she's proudly a mother of 2 children. So, endocrine causes. Amongst the endocrine causes, we have uncontrolled diabetes. Uncontrolled, that is the word, not just diabetes. You can be diabetic and you will not have miscarriage as long as your sugar is well controlled. But if it is uncontrolled, before you get pregnant, especially there's a test we call hemoglobin A1C, glycated hemoglobin. It shows you the degree of control in the last 3 months for your blood sugar. So if it is elevated, greater than 7%, that woman should not get pregnant until it is controlled. That is why we always advocate that women who are diabetic, they must have what we call preconceptional care. They should come and see their doctor and tell the doctor, doctor, I want to get pregnant. So that together you and your doctor will work things out and make sure when you are getting pregnant, you are safe and you're going to have a baby who is healthy. Another endocrine cause is thyroid disorders. Thyroid disorder can come as hyperthyroidism or hypothyroidism. Now, for diabetes, sorry, before I go back to thyroid disorder, there are certain symptoms that you can present that will be a pointer towards diabetes. One can be extreme weight gain or weight loss. Then you can also have excessive thirst. You just discover that you always want to take water, you always want to take water. Then you pass urine in very large quantity, or you are having recurrent vaginal discharge, recurrent itching, or recurrent boils all over your body, or you are having recurrent miscarriages. All this can be a pointer to diabetes. So you need to have the test done to exclude diabetes. Then for thyroid disorder, again, if the patient is hypothyroid, she can have excessive weight gain. Then there will be what we call heat or cold intolerance. When everybody is hot, this person will be complaining of cold. She cannot tolerate cold. When everybody is cold, she will be complaining that she is hot. So she behaves in the opposite of the general population. Then for those who are hyperthyroid, they tend to eat a lot and they go to toilet often, frequently, and they may have increase in menstrual flow. So all this will point towards a thyroid dysfunction. So you also have to do your thyroid function test to know if you are hyperthyroid, euthyroid, or hypothyroid. Then again, there's what we call polycystic ovarian syndrome. In PCOS, these women are usually obese. They have what we call insulin insensitivity, and they also have multiple cysts on ultrasound scan. The main problem with them is their menses is usually not regular. They have irregular menses and they have difficulty getting pregnant. Then when they now get pregnant, they are often at risk of having miscarriages because they already have insulin insensitivity and their androgen hormones are elevated. The androgen hormones are the main hormones. They have it in excess. And they now also have what we call diabetes. So these three things together is what makes them at risk of recurrent miscarriages. So their own case is very peculiar. So when they get pregnant, you need to give them hormonal support to help support the pregnancy so that they will not have a miscarriage. Then another hormonal cause is what we call luteal phase deficiency. Some women do not have a problem getting pregnant at all. All they have the problem with is keeping that pregnancy. And there is a hormone that is responsible for making the baby stay, especially in the early parts. It is called progesterone. And this progesterone is secreted by the corpus luteum, which is like the ovary that was secreted during ovulation, which will now transform into a corpus luteum that sustains the pregnancy until the placenta is formed. During that time, if there is a deficiency in this luteal phase of the pregnancy, they will be having recurrent miscarriage. They will suddenly feel they are pregnant. They do a test. Pregnancy test is positive. After 2 weeks, negative. There is a defect in the luteal phase. So once you identify these women, as soon as you have started them on the workup for fertility, after ovulation, you start them on luteal support with progesterone. This helps to carry the pregnancy to term. And so we move on to another cause, which is what we call infective causes. Now, today I'm going to really disabuse our mind. Previously, We used to think that there's what we call the touches complex. There are infections that are present that they have been claiming result in miscarriages. You have toxoplasmosis, syphilis, and all of that. Now, those touches complex are not actual causes of miscarriages. They are not actual causes of miscarriages. What will actually cause miscarriage has to be a predominant infection that is present in the pelvis. And that infection will just go unnoticed. Most times when women have this touches infection, they have symptoms and so they get treated. So what usually happens is they may have some congenital problem in the babies. The babies are usually born at 10, but the babies will have some problem. It doesn't necessarily result in miscarriages. But there are some infection that will just come up suddenly during the early course of this pregnancy. And this infection, if not attended to on time, will result in miscarriage. One that is very common is malaria. That is why our pregnant women should not joke with malaria. As simple as malaria is, it can be very, very detrimental to one's health. So, once you start experiencing the symptoms of malaria, quickly seek help so that you will get the appropriate anti-malaria to take in the early part of this pregnancy that is safe for you, so you will not have a miscarriage. Another one is urinary tract infection. And urinary tract infection is very common in the early part of pregnancy, and it's also common in women who are diabetic. So if you do not treat it on time, it can result in miscarriage. It can also result in preterm labor. Then we have other infections like corona, which was with us, started about 3 years ago. Coronavirus, most times when women come down with coronavirus infection, the next thing, if they are pregnant, is they definitely have miscarriages. So there are studies still going on why will coronavirus make these women have miscarriages. Now, coronavirus also causes thrombosis, which is formation of clots within the placenta bed. And once clots are formed within the placenta bed, blood flow will not be normal. There will be impediment in the blood flow, which will result in uteroplacental insufficiency, which will now result in the death of the fetus, resulting in miscarriage. Then we also have Lassa fever in areas where you have this Lassa rats. So our women who come down with Lassa infection are also at risk of miscarriages too. Then there are some women who work in certain places that as soon as they get pregnant, they are advised to leave those places or they are transferred to another location. Example, women who work with chemicals. Some chemicals, just inhaling it alone, can be very toxic. Some anesthetic agents too. So if you work in an area where you are prone to having exposure to high dose of chemicals and you are having recurrent miscarriages, that may just be the cause of this miscarriage. Then we now have what we call your inherited thrombophilic deficiency. These are some conditions which we inherit. Now, in our local settings, we cannot actually make such diagnosis, but they do exist. That is why when we tell patients you have unexplained cause of miscarriage, we cannot actually say unexplained until you have done all the necessary tests for these patients. So some of these tests we cannot do in developing countries. But when you go to developed countries, as soon as you are having recurrent miscarriages, they just take your sample and run a thorough screening for you. And they tell you, you are this, you are that, you are this. Okay? One of them is you have protein C and protein S deficiency. When you have protein S and protein C deficiency or antithrombo3 deficiency, it results in thrombus formation, which is also clot formation again, or some bleeding disorders. And these women tend to have recurrent miscarriages. Now we know the causes of miscarriages. How do we investigate these women? One thing is to know the cause. Another thing is to actually know, is this the exact cause? That is why all women who are experiencing miscarriages need to be managed by people with the requisite skill and expertise. You know, our women are very emotional. So once they've had one or two miscarriages, they start seeking for help in anywhere they feel help can come from. And that's where their problem actually starts from. They don't seek help in the appropriate place. They seek help from the wrong people. They should seek help from experts who are trained in managing miscarriages. In fact, what we now advocate is they should have a specialist miscarriage clinic. This doctor is a doctor who is trained in managing miscarriages. So you know exactly what to do for these patients once they come. Managing them, you must be very empathic and sympathetic and compassionate, because it's not easy to keep losing babies, one, two, three, when people are already ticking the day you got pregnant, your last menstrual period. You see, the woman gets very emotional and she may result in overt depression. So they should be managed by expertise with the requisite skill. Now, in a clinic for miscarriages, the first step is history taking. You must know how long she has been pregnant, how these miscarriages usually occur, what are the symptoms present in this woman. Like I mentioned some of these symptoms before. From the symptoms alone, you will know the test to do. Then, there is something we don't usually do. Once a woman has had a miscarriage, it may occur in the house or in the hospital. The doctor may complete the procedure. Whatever you are bringing out from the body of the woman, or whatever has come out, which we call retained product of conception, it should be sent to the lab for histopathological evaluation. And if possible, karyotyping should be done, because it is only from karyotype that you will know if it's as a result of chromosomal abnormality, either from the father or from the mother. Again, if this miscarriage is becoming so worrisome, you can take blood from the father and the mother too, and also check their karyotype, their genetic makeup, to know, is there any genetic problem with these women or with their partners that has resulted in these recurrent miscarriages. Then, if you are thinking towards antiphospholipid syndrome, you must do the screening for antiphospholipid antibodies. And when you have two positive tests in the space of 12 weeks apart, and what are the positive tests? When you have a lupus anticoagulant, or you have anticardiolipin antibody of IgG or IgM, or anti-beta 2 gamma protein 1. Once you test for this and it's positive, you say, yes, this woman has antiphospholipid syndrome. It is already diagnosed. For those you suspect fibroid or uterine abnormality, you will do a pelvic ultrasound scan. Check the uterus. With ultrasound, you will see the fibroid. You can do hysteroscopy. Hysteroscopy is when you are using a microscope to look inside the uterus. If there's a submucous fibroid, you will see it and you can bring it out. If there's a uterine abnormality, you will see the abnormality. If she does HSG, you will see the abnormality in the uterus. So you'll be able to know that this is the cause of recurrent miscarriage in this patient, and then you can treat it. For those that have thrombophilias, so you can screen for the thrombophilia. You do protein S screening, protein C screening, anti-thrombin screening. All these tests can be done in a very equipped laboratory. And then for the local ones we can easily do that are not so expensive, you have what they call the thyroid function test. Thyroid function test is best done in the morning when the patient has not even eaten and she's fasting. You will do her thyroid function test, check for T3, free T4, and thyroid stimulating hormone. Depending on the results, you cannot classify this patient as euthyroid, which is normal, hypothyroid, or hyperthyroid. And then, for those you suspect diabetes, the exact test to do for them is the oral glucose tolerance test. By oral glucose tolerance test, it means this patient will have, just leave her to take her normal meals. Don't restrict her carbohydrate or protein intake. All she has to do is abstain from smoking. Then she should come early to the lab the morning of the test. When she's properly seated, at least she should fast for at least 8 hours, 8 to 10 hours. After her fast, she will come to the hospital in the morning, sit down comfortably. She should be in the hospital at least by 7:30 in the morning. 8 on the dot, you take her first sample, which is called the fasting blood sugar. Then you will now give her glucose that is mixed with water to take. You can use either 75 gram or 100 gram of glucose, and she takes it gently within 5 to 10 minutes. After 1 hour of taking that glucose, you will take a sample from her blood, you do the test. After 2 hours, you take again. If you are using 75 gram, you will take the blood test 2 times. If you are using 100 gram, you take it 3 times. At the end, you will go through the results. Once you have any abnormal results, you will know that this woman has impaired glucose tolerance. Do you understand? Then you can now refer her to the endocrinologist who will manage her sugar. OGTT, as simple as it is, has been saving so many lives. Diabetes is with us. Diabetes has come to stay. The only thing that can help us is lifestyle modification and early detection. And even if not for the recurrent miscarriages, it has so many complications that can result if you do not treat it. So it's very important that we should all do this test so that we know our health status. Then for women who have recurrent discharges, remember I said a long-standing pelvic infection can result in recurrent miscarriages. And one that is very notorious is what we call bacterial vaginosis. Bacterial vaginosis is a mixed infection. Different type of bacteria come together and stay in the woman's pelvis, in the vagina, and it gives a very bad odor, fishy odor. So if it is there, it can result in preterm delivery and recurrent miscarriage. And the treatment is very, very simple, readily available. First and foremost, take a high vaginal swab or an endocervical swab for culture. Once you make your diagnosis, you give her treatment. Clindamycin, metronidazole, and the woman is fine, and she'll be able to carry her pregnancy to term. So the treatment for recurrent miscarriage is according to the exact cause. If it is infection, you treat infection. If it is malaria, treat malaria with anti-malaria. Urinary tract infection, as soon as a woman notices she's having pain while passing urine, she's having fever, she should not stay at home and be treating herself. She should run to the hospital immediately, because if she doesn't come on time, it will result in a miscarriage. If she has Lassa fever or contact, she should get treatment. Same with corona. Vaginal discharge, the same thing. If she's diabetic, follow up with endocrine, either on insulin or oral hypoglycemic agents, or just dietary control, and her sugar will be okay. If she's hypothyroid, she'll be placed on tyrosine, and before you know it, her thyroid function will result back to normal. All these are not far-fetched, they are
Hmm.
readily available.
Available.
And now, if it is antiphospholipid syndrome, which is now very common, it complicates about 25% of cases. If you see couple having recurrent miscarriages, by the time you screen them, 25% have antiphospholipid syndrome. which we cannot readily diagnose. And the treatment is very, very simple. That is why we tend to give some of our women aspirin and heparin, Clexane, as soon as they are pregnant. This will help to prevent thrombosis in the vascular bed and ensure the vasculature of the placenta bed, they are open so blood can flow well. There is no insufficiency, and as such the baby will be carried to term. Then for those that have luteal phase deficiency, they are given progesterone. Progesterone can be given as either injection or vaginal or rectal pastries or oral tablets, depending on the one you can afford. And as soon as you take it, you will have no problems. Miscarriages are very common, and the management needs to be by experts who is trained in managing such cases. So we advise our women who have been having this kind of problem, solution has come, help is around the corner. Seek help from the appropriate authority and make sure this problem is brought to an end. Thank you very much.
Thank you very much, Ma. This is just a lecture. I wish people were even taking notes and documenting, writing, because I don't know what anybody would look for again in understanding miscarriage. And Dr. Hilda has spoken about the definition, the causes, risk factor, the place of lifestyle, the place of age, and those having recurrent miscarriages, what to do. Um, I hope that we have gained a lot. Ma, there are a few questions I want to ask. These are questions that people actually sent to me with regarding miscarriage. The ones that you addressed in the video, I'm not going to repeat them because the answer has already been taken care of. So a lady asked me this question. Her name is Mary Queen. She says, is it true that a woman who always have miscarriage needs to tie a certain rope on her waist immediately she takes in to avoid another miscarriage?
Thank you very much for that question. My dear Mary Queen, there are myths about miscarriages. Like I said, in our traditional setting, so many things people have said to prevent miscarriages. But I can tell you, these things do not have any scientific basis or knowledge whatsoever. Tying a rope will not prevent you from having a miscarriage. If you must tie a rope at all, that rope has to be tied by the doctor, and it's not to be tied in the waist, it has to be tied in the cervix. This is for women who have what we call cervical incompetence. They need what we call cervical cerclage, and this cerclage is a thread that is tied in the cervix to prevent the cervix from opening. So tying a rope in your waist will not stop you from having miscarriage. Putting pin in your cloth as a pregnant woman will not stop you from having miscarriages, okay? If you are prone to have miscarriage, miscarriage will occur unless you identify the cause and treat it. So disabuse your mind from those superstitious beliefs. Thank you.
Thank you very much, Ma. Another question here from Joy Ome. I know you addressed it during the discussion about the septate and biconduit uterus, but she's asking, what are the chances of getting pregnant when you have a septate or biconduit uterus?
Once you have a septate or a biconate uterus, you can have a surgery, which we call a metroplasty. They break that septate and the uterus is free and you can carry your pregnancy to term. I have seen women with such abnormalities who actually carry their pregnancy to term. Most of them, we do an elective cesarean section for them to deliver because they may have some problems with the labor process, but they have carried pregnancy to term. So that is not a problem. If you have such problem, visit your specialist so that you can get treatment for that condition.
Thank you very much, Ma. I know we don't want to take more time. This one is very important. So I've seen this question a lot and I decided to document this. A lady says, I had miscarriage. When should I try again to meet my partner? Do I try immediately or I have to wait? What are the processes? What steps do I need to take to get pregnant again? So she just finished having a miscarriage and now she wants to get pregnant again. Most likely she's desperate. When should she meet her partner? What should she do? What advice would you want to give to her, ma?
Well, there's no hard and fast rule about it. Once a woman has had a miscarriage, the very most important thing to do is try to identify the cause of that miscarriage before you try to get pregnant again. Because when you get pregnant again, there is a likely percentage that you will also have a miscarriage. And there is one risk factor. A previous miscarriage also gives you a higher risk of having another miscarriage. So you must ensure that what caused that miscarriage is no longer present before you try to start having another baby. And usually after a miscarriage, we advise the women, allow the body heal, allow the bleeding stop, be ready psychologically and emotionally to be pregnant again. It's not easy. So some women easily get out of it. 3 days, they're already out. So if you can tolerate, why not? It's just as the same question our women who deliver vaginally always ask, how soon can I resume sexual intercourse? We tell them, as soon as you are comfortable. So there is no hard or fast rule about it, but try to rule out the cause of that miscarriage first before you get pregnant again, so that what happened before will not happen again. Then you try to study your cycle too, because when you've had a miscarriage, there's a disruption in your cycle. So it is advised, see your next menses before you plan on getting pregnant again, so that at least you can make some calculations. You can date your pregnancy. It's very important.
Thank you, Ma. I think one is it one more or two more questions? Yes. The place of stress and its effects on miscarriage. I've heard a lady say that, oh, I was pregnant, and then when I went out, there was so much gallop on the way. That is why I lost my pregnancy. Now, this next pregnancy, I'm not going to go anywhere. Is it right? What would you advise, ma?
Well, we also have individual variabilities. There are some women who are pregnant, they go to farm, they climb tree, they do everything and nothing will happen. Do you
Nothing
understand?
happened.
Nothing happens to them. There are some young girls that get pregnant outside wedlock. There is nothing they will not do so that they will have a miscarriage, and still nothing will happen. So it all boils down to your personal composition as a woman. But in such instance, there are some women that have weak cervix, like I said before. If this woman has a weakness in the cervix, any little trauma or stress can predispose her to having a miscarriage. These are like the women that we usually put a circlage for. They are also the ones that we advise that as soon as they get pregnant, they should try as much as possible to abstain from sexual intercourse. I'm surprised they have not asked this question. There are
Mm,
some of our women, when they have recurrent miscarriages like that, we just advise as soon as you get pregnant, please abstain from sexual intercourse. It's a form of stress too, so that by the time the pregnancy is now advanced, you can now resume your conjugal activities. So if she has had a bad experience previously due to a stressful condition and she can prevent it, why not prevent it? But I
mm,
can tell you there is no scientific basis for that. But if you know your body and it's happened before as a result of stress, the early part of a pregnancy is usually stressful for everybody. It's stressful for the patient. She's trying to adjust to a new life growing within her. So many changes occur. So if she has not adjusted properly and she's not prone to stress, problem for her.
mm.
There are some women, the moment they miss their period, they are already admitted in the hospital. They cannot cope. Why some? They will go to work. If they don't even tell you they are pregnant, you will not know. So it boils down to individual differences. That's what I can say about that.
Yes, individual differences. You know yourself. Okay, Ma. This one is the last one. This person says, "Can miscarriage be hereditary?"
No, what we mean by genetic, that's why I said genetic predisposition means the gene is coming from either the partner or the patient. It takes two to tango. The male contributes, the female contributes genetically to the formation of the fetus. So
Hmm.
if the male has any genetic abnormality and he transmits it to that baby that is forming, the baby will have a problem genetically and it will result in miscarriage. The only type of miscarriage that can occur as a result of hereditary is when there is a connective tissue disorder. Connective tissue disorder, we have Ehlers-Danlos syndrome. These women, their mothers had connective tissue disorder. One. Or these women, when their mothers were pregnant for them, those, I don't think that is common again. At a certain time, there's this medication they call diethylstilbestrol. It was used to treat some form of problem long ago, let's say around in the 1970s. So women who took those medications, when they got pregnant with female children, that medication caused connective tissue disorder in those female children. So those female children, when they now grow up to become young girls, they now had cervical incompetence. So that is a form of hereditary cause of miscarriage. Aside that, any other thing is genetic or epidemiological. So I
Hmm.
don't think you will still have diethylstilbestrol daughters again, because around the early 80s, those medications were banned. So nobody uses them again. And even at that, you can't, even if you ask some of all these are women, were you exposed? They cannot tell you because their mothers cannot even remember. But that is the only hereditary cause, and it results in cervical insufficiency. And the type of miscarriage is classical. It occurs from the second trimester. The pregnancy would have been well formed. She would suddenly feel a bulge in the vagina, and the next thing she sees, her water breaks and the baby comes out. She will not even feel any pain. It's just like having a labor. Baby comes out and that's it. And it will occur one or two times like that, recurrent. Aside that, no other genetic cause.
Yes. So, thank you very much, Ma. Ma, I don't know if you have any final words on this topic. Any final advice for ladies, ladies having recurrent miscarriages who are depressed, thinking all hope is lost. What will be your final words for them, Ma?
Well, my fellow women, miscarriage can be very traumatizing and devastating. I would encourage you, do not lose hope. There is no problem without a solution. You have not gotten to the right place. That is why you have not found a solution to your problem. With what you have learned today, I will advise you to seek help in the right place. Seek help with the right person who has the requisite skill, knowledge, and training to manage you. And you'll be amazed at how soon your problem will be solved. There is no woman that will definitely not have a child. All you need to do is have faith, believe, so long as you have a uterus and you have money, you will have a baby. All is not lost. Okay?
All is not lost. Chief had to add the area of faith to encourage you that as we're treating you, you also need the part of faith. Ma, I know
Yeah.
that some people have been trying to reach you. Sometimes you have this online consultation, you speak with people. In case anybody wants to out to you, how can they get in touch with you?
Wow.
I do get that always online. I tell them I'm very, very busy. I don't know in case they want to reach out to you. Is there any way, or I have to send them through your inbox?
Most likely.
Okay.
Because once you give them your contact, they will frustrate your life.
Yeah.
They don't know when you're at work, they don't know when you are busy, they just keep calling and calling and calling. So I think
Yes.
if it's absolutely important, you want to reach out, you have some gray areas you want to clarify, they can just send me a message in my inbox. Definitely I will read it and I will definitely respond.
Thank you. Thank you very much, Ma. Ladies and
Thank you
gentlemen,
so
you
much.
just listened to Dr. Hilda Iyen Omoregbee, a consultant obstetrician and gynecologist. She's also a fetal maternal specialist. He's a high chief, triple chief. So when we say chief, we're saying chief medical, chief every area, and it's a great honor to have her on this platform. The last time she came here, spoke about danger signs in pregnancy. We had to break it into different clips and posted it on Facebook, on Instagram, on TikTok, and people have been comment, oh yes, I gained a lot. And I hope that this one too, we're going to cut part of this clip and paste it on other social media platforms. We are grateful, Ma. Thank you so much for your time. And God bless you and continue to elevate you. And you keep getting more and more award and more money in your account.
Amen. Thank you very much, Dr. Fred, for the good work you are doing. You're actually trying to reach out to everyone. Keep it up. We are proud of you and we're very happy. Thank you very
Thank you.
much. God bless you too.
Thank you so much, Ma. Take care of yourself and have a wonderful evening, Ma.
All right. Bye. Masalama.
Bye bye. Bye bye, Ma. Yeah, thank you, everybody. This was such a wonderful session. Somebody is making a comment, so I just need to respond. I send you a message on WhatsApp. No, my dear, I don't respond on WhatsApp. I don't respond on WhatsApp. My PA will respond to you. If you want to have a consultation, you would have to book. That is not my personal number. Huh? I'm sorry, love. If you want to speak with me, I'm sorry. You will have to book for a session, and my PA will tell you what you need to do. I don't do the WhatsApp chat to people. Thank you, everybody. Take care of yourself. Remember, good life. That's sense. Bye bye.